Okay, you guys, I want to talk to you a little bit about the central nervous system and comparative pathology. So here's some learning objectives. I want to look at the A&P, or anatomy and physiology of the central nervous system, talk about imaging considerations, and I don't want to just look at CT type stuff or X-ray type stuff. We will talk a little bit about radiography, but a lot of this conversation is going to be about MRI today. So we'll look at some pathology of the central nervous system to include spina bifida, hydrocephalus, meningitis, etc., etc. And we'll wrap up with neoplastic disease. So here's a general overview, and our textbook has got much better pictures than what I found. But what we've got is, anytime we're talking about the central nervous system, we're talking about the brain and the spinal cord, and it's made up of neurons and neuralgia, which work together to conduct electrical chemical signals, of course, from the brain to throughout the body, as well as from the body to the brain. And it functions to help our organs survive, largely through the use of neural function for memory, as well as for control of bodily function. Within the brain, we've got the cerebrum, cerebellum, diencephalon, and the brainstem, which includes the midbrain, pons, medulla oblongata. And the medulla oblongata is probably one of my favorite anatomic terms. It's helpful for us to look at the meninges, and if you look at the figure 8-2 in our textbook, you get a much prettier picture. But when we're talking about the meninges, we're talking about those almost like the sac that contains the brain and keeps it kind of protected within the skull, because the brain is really just a giant piece of fat. Because the fat is an insulator around the neurons. So all the white matter in the brain is being used for insulation purposes primarily, and it's just this gelatinous blob. So the meninges really function to kind of keep the brain in order. The outside part is called the dura mater, which means the hard part. The arachnoid layer is it's named that because it looks like kind of spider webbing, and so the textbook has a really good drawing of what that subarachnoid space looks like. And then the part that adheres most closely to the brain itself is the pia mater. And the function, again, I've already mentioned. The ventricles function to help provide the brain with nutrients, as well as, again, to help it kind of maintain its form. And a lot of anatomic deviations or pathology will impact the ventricles of the brain, so we'll see a shift of the ventricles, particularly within the lateral ventricles, or we may see kind of an obscuring of the third and fourth ventricles. Again, there's really great illustration of this in our textbook, figure 8-3, gives a really pretty picture of where that fourth ventricle is located, and a third ventricle as well as that what we call the cerebral aqueduct that communicates between the third and fourth ventricles. Blood supply is really important for the brain. Without it, we are talking about things like a stroke. And so again, there's another illustration on 8.3 in our 8.4 in our textbook, which is much better than this, and it shows kind of how those arteries enter the brain and how they kind of branch throughout the cerebellum as well. So the bilateral internal carotids are going to feed into the circle of Willis area here, and the basilar artery kind of feeds into the circle of Willis as well. And one of the things that's significant for the function of the brain in terms of both the way the arteries function in the brain and also the way the brain functions with getting rid of blood is that there is this brain-blood barrier, and it is an osmolytic barrier that permits only certain things to cross over into the brain itself. This is a protective barrier that exists in the brain, and it's one of the reasons why certain drugs can't enter into the brain and things like that. Or, for example, when we're doing CT contrast, why we have to wait like a 5-minute delay prior to doing brain imaging. The last thing I'll mention about the brain is that there's not really veins within the brain. There's the sinuses. So once the blood has circulated through the gray and white matter of the brain, it drains into like the superior sagittal sinus, or these sinuses towards the rear of the brain, like these confluence of sinuses, straight sinus, and down into the sigmoid sinus, and ultimately enters back into veins. Final thing on this slide talks about is intervertebral discs, and we'll look at those briefly today, but we're no longer talking about the brain, we're talking about things within the spinal cord, and these are discs that make up the actual spinal cord and serve to kind of provide stability and function, as well as almost like shock absorbers for the body. When we're trying to image within the central nervous system, radiography is not going to be our go-to thing. MRI is going to be our best option for imaging most everything inside of the central nervous system because of its increased ability to detect disease, to evaluate for tumors, stroke, cranial tumors, any kind of infection, multiple sclerosis, and it can also depict expansion and compression of the spinal cord as well. It has a limited role for evaluating trauma, so that largely will still be done by CT. But all of these different developments in MRI are of particular interest, so I encourage you to pay attention in your MRI class. Things like functional MRI imaging actually allows us to see how the brain is functioning, what areas of the brain are conducting during different thought processes. In fact, there's even discussions around fMRI polygraph tests and things like that. Diffusion weighted imaging allows us to see what areas of the brain have greater magnetization or less magnetization. They'll appear different colors, and it actually allows us to understand like how different neurological fibers are functioning. We're going to look at some MRI images, so I just wanted to kind of loosely cover what the textbook discusses in this area and make sure that we are familiar with what those images look like. Of course, CT, I'm a big fan of CT, and CT does do a very good job. It has a high sensitivity and specificity, particularly for stroke. In order for us to see things like infection or tumor, oftentimes we do have to introduce contrast for CT. So that's one advantage that MRI has. Oftentimes we can do an MRA without any contrast administration. And then I want to give a shout out to ultrasound. A lot of times they get short shift, but ultrasound of the brain is amazing for neonates. So before the soft spot of the skull closes off, we can do ultrasounds of the brain, and they're beautiful pictures. Nuclear medicine, of course, is continuing to improve brain imaging, and of course vascular and interventional radiology. I'm not going to touch on those so much in this lecture though. So first area of pathology that we want to consider is hereditary stuff. And so meningeomyelocele, spina bifida, this is a very serious condition. It can be broken down in different ways. So I want to look at that real briefly. I'm just kind of scrolling through here. The different ways that we talk about these things. So any of these hereditary disorders of the spinal cord, anytime we're talking about meningeoceles, myelocele, these are any error within the meninges that allows for the spinal cord to protrude out. And this is oftentimes can be diagnosed prenatally, so before the child is born, and so they can do a surgical closure in order to treat this. So a meningeocele is if only the meninges are protruding, and that can be treated surgically without difficulty. A myelocele is a protrusion of the actual spinal cord minus the meningeal coverings, and this is also treated surgically. A meningeomyelocele is the most common, and it's the most serious of all these conditions, and it affects about every 1 in 800 infants. And so both the meninges and the spinal cord are protruded into the skin of the back, and this is going to affect patients' neurological function, and it has to do with the extent of impairment will be directly related to the extent of herniation. So things like diminished control of the lower limbs, bladder and bowel function, and oftentimes also hydrocephalus may be a secondary result. Here's examples of what these different things look like, and this just comes straight from the textbook. So nothing really to add to that. Here's an example of a sagittal image MRI showing, I believe, a meningeomyelocele. And it's used, yes, meningeomyelocele, and we've also got some gadolinium contrast on board, so we can actually see where exactly the spinal cord is at. Hydrocephalus, we can have both communicating and non-communicating forms. Normal circulation is interrupted. Normal circulation of cerebral spinal fluid is interrupted, and this causes an obstruction, right? And so this would be non-communicating hydrocephalus, or perhaps impaired absorption, so we would call this communicating hydrocephalus. There is some amount of circulation going on, but not much of it is being absorbed. And all of this results in an excessive accumulation of cerebral spinal fluid, which causes excessive compression and on the brain and atrophy of the brain itself. The word hydrocephalus literally means water on the brain, and that is quite literally what's going on. Causes for this depend on whether we're talking about non-communicating or communicating. So a non-communicating causation can include something like a tumor growth, trauma, or inflammation. Oftentimes communicating has something to do with an actual disorder that's causing that non-communicating hydrocephalus. Oftentimes we can do sonography in these cases, and treatments oftentimes include a shunt. So we'll look at both those things now. So here is some MRI images of both a normal brain and a hydrocephalus brain. And one of the things to mark is just how enlarged the ventricles are on the brain in a hydrocephalus case, and how that has caused significant atrophy of the brain itself. And this lateral X-ray image here is of a shunt that's being used to drain the cerebral spinal fluid, and oftentimes it's drained somewhere into the abdomen, maybe within the peritoneum. Maybe it's just drained back into the heart. We don't really care where exactly we place the drain end. It is significant where the drain or origination is placed. Let's change gears just a little bit and look at inflammatory processes within the central nervous system. The first we'll talk about is meningitis. This is a very severe inflammation that causes within the meningeal coverings. It can be caused by bacteria, viruses, or other organisms. Bacterial meningitis is the most common. It can be difficult to diagnose, and oftentimes it will require like a spinal tap to diagnose it. And it is important whether it's bacterial or viral. And so if we diagnose bacterial, the treatments would be like an antibacterial type treatment. This can result in hydrocephalus, like I mentioned earlier. So hydrocephalus can be linked to, especially non-communicating hydrocephalus, can be linked to infection, which causes swelling, which causes increased pressure on the brain. And so there's considerable secondary effects of meningitis that can cause other problems. Another example of infection within the brain tissue is encephalitis. So in contrast to meningitis, which is most frequently a bacterial infection, encephalitis is normally viral in nature, and it's going to be caused by conditions like, for example, chickenpox, smallpox, influenza, measles, which has spread to the brain. It can be transmitted by mosquitoes during warm weather, herpes simplex virus, which we'll look at here in just a minute, which can include children. And so oftentimes I know that within nurseries, they talk about how the little kids have got hand, foot, and mouth disease. That is herpes. And so, teaching our kids not to put things in their mouths is important. And oftentimes the signs and symptoms related to encephalitis are things like headache, malaise, so feeling weak, or even a coma. And that just depends on how serious it has progressed. The diagnosis is definitely going to be enhanced by labs and X-ray. So or MRI, I should say. Here's some example of MRI images of a patient with herpes encephalitis. It's actually a small boy, and we can see how MRI lights up really clearly with, these are T2 weighted images, with the area of infection. Another inflammatory process is a brain abscess, and if you were to ask me what's the number one place I would not want an abscess, it is within my brain. And so we can view these both on CT and on MRI. The mortality rate for brain abscesses is really high. It's decreased some because we're able now to treat them surgically, and we're also able to diagnose them where in the past they were very difficult to diagnose. CT can be used. Oftentimes we will need to introduce contrast to view it on CT, but with MRI we're going to have greater sensitivity and specificity, so both the T1 and T2 weighted images can allow us to evaluate the abscess wall. So here's a really lovely picture of a loculated abscess. You can actually see it's got little different compartments of oozy, pus-filled infection inside of this individual's brain. Um, Anytime we have a abscess within the meningeal layers, like within the dura mater or the arachnoid mater, we'll call it a subdural empyema. And so, like a brain abscess, these subdural empyemas are diagnosed with CT or MRI. All right, let's talk about degenerative diseases of the spine. This is a really crappy MRI picture of herniated nucleus propulsus. Causation of this is this degenerative disease, so weakened or torn annulus fibrosis. It can rupture, and this causes the nucleus propulsus, that kind of soft spot within the spinal disc, to protrude and compress into the spinal nerves, which you can imagine causes quite a bit of pain, and often has to be treated surgically. Causes of this can include just kind of poor health, uh, being overweight, as well as some degenerative disorders that just occur with time. Uh, MRI is going to be critical. Oftentimes, if we can't do MRI, like if they've had surgery and the metal in their back is causing the images to be obscured, we can do CT, but oftentimes it has to be preceded by myelography, so we have to inject IV contrast into the area of the thecal sac around the spinal cord. So this is not technically IV contrast, it would be intrathecal contrast injection. We do that under fluoroscopy, and then we transfer the patient to CT for the actual CT imaging of the spine. As you can imagine, that's a more invasive procedure than MRI, which can be done without any contrast at all. So sometimes we talk about discography, where we actually kind of image the discs. So you can imagine on MRI, it's really nice. You can set up these nice, neat axial images of individual discs, which particularly in the lumbar spine region is nice because they have slight different angulations, and you can get true axials of each disc and evaluate what part is actually herniated. Treatment is typically surgical or physical therapy or just weight reduction. Cervical spondylosis is when a similar thing is occurring within the cervical portion of the spinal cord, and so this is a lot of, as you can imagine, since we're higher up on the spinal cord, there's significant collateral problems that can happen from this. We're talking about chronic nerve root compression. Some of these are osteoarthritic changes, so not so much having to do with weight, but having to do with loss of mineralization within the spine. So bone spurs can be formed, which I think we actually can see in this case here. And these can also cause irritation of the spine. MRIs can be very, very important for looking at these changes in contour of the spine, and its sensitivity is just kind of off the chart. Oftentimes this may also be complemented by bone scintigraphy, so SPECT imaging, and treatment of this may be surgical or it may be drug related. Multiple sclerosis is another chronic progressive disease of the nervous system that typically most commonly affects individuals like in their 20s and 40s. It affects women much more often than men, and the exact etiology or causation of the disease is largely unknown, but it may be related to a latent herpes virus or retrovirus infection, and it oftentimes happens with folks living in temperate environments like our own. So it causes degeneration of the myelin sheath and the white matter, and we see these MS plaques that are apparent on MRI images, and this is highly suggestive of multiple sclerosis. This is an axial fluid attenuation inversion recovery, so FLAIR image. Anytime that we suspect multiple sclerosis, if we're working in MRI, this FLAIR imaging is critical. It's one thing I learned in my brief time in MRI, is how important it is that if they're looking for multiple sclerosis, if we suspect multiple sclerosis, if the patient is talking about signs and symptoms related to multiple sclerosis, we need to do this FLAIR imaging in order to guide diagnosis and treatment. Prognosis related to this is the patient's lifespan is not necessarily shortened, but the patients will need to go on corticosteroids to shorten the symptomatic period. So they'll have good days and bad days. Most patients benefit from regular exercise, alterations in diet, and physical therapy in conjunction with the medications. All right, switching gears again, we're going to talk some about vascular disease. So you'll notice I'm jumping over the textbook's discussion of things like dementia and stuff like that, because largely we still aren't able to really diagnose dementia with MRI imaging or CT imaging, although I imagine that may change in the course of your lifetime. But I'm skipping over quite a bit to arrive at the CVA, cerebral vascular accident, commonly called the stroke. There's about close to 800,000 strokes per year in the United States of America, so that results in an average of one stroke for every 40 seconds, so about one stroke every minute. And it's the fifth leading cause of death in the U.S. It kills about 130,000 Americans every year. There's two forms of stroke. So this slide actually is, incorrect. Let me point that out. The slide is incorrect. Stroke, according to the textbook now, is the fifth leading cause of death, so the slide's a little bit old. There's basically two different types, ischemic or hemorrhagic stroke, and that is important for us in terms of treatment. Hemorrhagic stroke is normally going to be a more sudden onset, and CT is highly sensitive to that. Ischemic stroke may be more difficult to diagnose because it can be very slight, but it is about 87% of all stroke cases are ischemic in nature. We're going to use CT and MRI. If those fail, carotid sonography or CE-MRA may be helpful. So ischemic stroke is broken down into, I think, 3 different types. Causes are an obstruction of blood flow to the brain, and that is largely often caused by a blood clot or a thrombus or an embolus. An embolus is just a mass of undissolved matter, so it could be an air embolus, it could be liquid, it could be a gas, but a thrombus is specific to blood. So a large blood vessel thrombus causes an infarction, and this reduces blood flow to the brain. So there's large vessel thrombosis, which we can typically see very clearly on CT or MRI. There's also small vessel disease, and these are the ones, the lacunar infarctions are the ones that are more difficult to see. So they may require like a CTA, a CT angiogram to see a little tiny area where the blood flow has been occluded, or an MRI. There's also transient ischemic attacks, and so this is like a temporary episode of stroke which resolves itself. And so if you can imagine, like a clot is thrown into the brain, but the clot dissolves maybe by friction or force, and the stroke symptoms pass, but we still need to consider treatment and things like that. Diagnosis is typically a non-contrast CT. The stroke protocol currently at our healthcare facility is non-contrast CT followed up by a CTA, and I think even diffusion-weighted imaging. MRI, MRA, PET or sonography may be used as well, but generally we prefer CT just because we want to get a diagnosis as quickly as possible. Prognosis is based on how quickly treatment occurs, so that's why we have things like a stroke protocol in place, because we want to give them a thrombolytic agent called RTPA, and the sooner we give them RTPA, the more quickly we can, or the less severe their prognosis will be. So it improves their prognosis the quicker we can give them that RTPA. Hemorrhagic strokes, where the blood vessel or what have you has ruptured and bleeding is actively occurring in the brain, we would not want to give them RTPA because it is a clot-busting medicine. And in hemorrhagic stroke, we actually want clots to form because the brain is actively bleeding. So these are typically result from a weakening of a vessel wall. So like the blood vessel is already diseased, it's weakened and it ruptures. So this can be caused by atherosclerosis, hypertension. It might also have to do with a congenital aneurysm or vascular anomalies like was the AV formations. Um, so basically, brain hemorrhages account for about 10 to 15% of all CVAs, and there's two types. There's subarachnoid and intracerebral. So subarachnoid within the meninges, or intracerebral within the brain itself. Um, and if it's within the brain itself, the blood oftentimes enters into the ventricles as well. Diagnosis a lot of times is enhanced by CT. So a lot of times we do the CT. Can we see a hemorrhagic stroke? No, but we're seeing all the signs and symptoms of ischemic stroke. That's why we've included CTA protocols into the non-contrast protocol, because if we cannot see a hemorrhagic stroke and there's not evidence of the ischemic stroke, we may need to follow up with some kind of CT angiogram. Prognosis, again, is based on the severity of the actual bleeding. If the aneurysm is able to be clipped, so this patient's rushed to surgery, if we can stop the bleeding, that actually improves prognosis. So here are examples of different types of stroke. On this image here, we have an MRI image of a 54-year-old woman who experienced left side paralysis, slumped forward, and so we can see the stroke is on the right side of her brain, left side paralysis. This is a large infarct having to do with the cerebral artery. So the MRI is powerful in that we can actually see the area of the infarct, the area where it's not receiving adequate blood flow. And then when we do this MRA image, where actually it'll say the occluded artery as well. So this just goes back to that increased sensitivity of MRI. Let's talk briefly about neoplastic diseases, so cancers of the brain. Primary tumors of the brain comprise only about 10% of all cancer deaths, but it's important when we're diagnosing to know is this primary or metastatic, and this has a lot to do with the neoplasm, location of the neoplasm, age of the patient, as well as their cancer history. Classification of primary brain tumors is largely based on the site and the histologic composition, like is it a glioma or a non-gliomal tumor. So here's a glioma. This is the most common type of primary brain tumor. About 45% of all brain tumors, primary brain tumors, are gliomas. Causes of gliomas, let's see here, scrolling along, is it's derived from glial cells, and we're still debating the exact classification for them. But several factors have been identified. It has having to do with the development of gliomas. It has to do with genetic information related to chromosome 17p, and these occur commonly in the cerebral hemispheres. The appearance on MRI is pretty stark. CT appearance, it would require contrast in order to visualize. Symptoms, again, are going to be based on location. So this might include things like headaches, vision impairment, personality changes, and seizures. Astrocytomas, kind of a subcategory of gliomas. And so this is about a third. These are the most common childhood brain tumor, and they're composed of astrocytes, which are star-shaped neuroglial cells with a bunch of branching processes. They're normally slow-growing, but the tumor can cause it to become a fast-growing thing. The oglodendroglioma is a slow-growing astrocytic tumor, and histologically it's often benign. But as you can imagine, there's a bunch of different classifications here. An epidemioma is a firm and whitish tumor that can arise from the epididyma and the lining of the ventricles, typically within the fourth ventricle. Medulloblastomas are soft infiltrating tumors of the neuroepithelial tissue, and these are rapidly growing and highly malignant. They occur in the cerebellum of children and young adults and usually extend from the roof of the fourth ventricle. They're more common in boys and rarely seen in adults. So one of the difficulties in trying to see this on CT is in the area where these originate. They're in the area of the fourth ventricle, we may have bone artifact or bone hardening that would obscure the tumor. And so MRI does not have that problem. So MRI is going to be highly specific and not have the bone hardening artifact that could obscure diagnosis. Treatment of these requires surgical excision of the tumor and possible radiation of the entire central nervous system, both the brain and the spinal cord. But the 10-year survival rate is still pretty low. Meningioma is a slow-growing, generally benign tumor that originates in the arachnoid tissue, and it's most common non-gliomal tumor. So it accounts for about 15% of all intracranial tumors. They're more frequent in women than in men, and although meningiomas often affect individuals of any age, they usually arise in adults between the age of 40 and 60 years of age. MRI, again, is going to be our friend. If we do a CT scan, it will need to require contrast in order to be clearly visualized. And treatment of these typically has to do with surgical removal, although we might do stereotactic radiosurgery. That's helpful as well with pituitary adenomas. These are benign tumors typically, and they are about 15% of all intracranial tumors. Anatomically, these are classified according to the size as well as the radiological findings. These can cause changes in hormone excretion, and because the pituitary is such an important hormone generating gland situated in the brain, it can cause gigantism. And so oftentimes we need to do something to treat this benign tumor, or the patient will experience acromegaly or gigantism if it occurs within childhood. Radiographically, we may be able to see this on a lateral x-ray. If we notice an erosion of the sella turcica, we can assume that is a cancerous process that's causing that, but generally we need to see it on MRI. Treatment a lot of times is a stereotactic radiosurgery in order to shrink that benign tumor. So there again is, you can see a little bit of that erosion of the sella turcica, although on MRI bone doesn't show it very clearly, but this is very pretty picture of a very ugly condition found on figure 8-47 in our textbook, a large pituitary adenoma extending downward. So thank you so much. Pretty much everything that we have looked at today is subtractive in nature. I think reinforcing that with the pituitary adenoma, where we actually can see a subtractive thing occurring on a lateral x-ray, is important to remember. Hopefully this has been helpful, and I'll see you around.